Well, thank you for this presentation. Thank you for this invitation. I really have to say, a really short time to prepare this lecture. And I have taken advantage that this weekend, I won't be able to join you on Friday because we have the Spanish consensus on portal hypertension, where I have to prepare some recommendation. My specific topic is about anticoagulation and portal vein thrombosis. I have taken advantage of some of those slides that I will show you. The agenda will be the mechanism of action of anticoagulants, just a reminder of them, the pathophysiological basis for the long-term use of anticoagulation in cirrhosis, and the experience with anticoagulants, which is portal vein thrombosis, whether anticoagulation improves survival in cirrhosis and specifically in patients with portal vein thrombosis that receive anticoagulants. Which is the mechanism of action of the most widely used drug, an old drug, I would say, as heparin. Heparin activates antithrombin, which inhibits activated factor 10 and thrombin. This is what unfractionated heparin causes. But the shorter length of the molecule of low molecular weight heparins is unable to inhibit thrombin to promote and cleave union of heparin, antithrombin, and thrombin. Therefore, low molecular weight heparins only inhibit activated factor 10. And this is an important difference. And a very much spoken and discussed about heparin is whether heparin is a molecule, is an anionic protein, which is able to bind any basic protein that is present in the circulation. Not only antithrombin, but also molecules related with inflammation, growth factor, and angiogenesis. And this is one of the main things that I will tell you. My point of view is that although this has been very much discussed, probably the efficacy of heparin and of any other anticoagulant in cirrhosis is related to their antithrombotic activity, not because of these potential and theoretical effects of heparin. And here you have, just a reminder, the different target of low molecular weight heparin, of vitamin K antagonists, and the new DOACs, those that inhibit factor 10 and those that inhibit thrombin dabigatran. And what are the bases for the use of anticoagulants in cirrhosis? Well, we have been showing these two references for more than 20 years. And really, although there is some evidence, they are not very well-proof evidence regarding the presence of microthrombosis in the cirrhotic liver that promotes progression of disease. What happens in the cirrhotic liver? In the cirrhotic liver, you have some factors that promote thrombosis. There is endothelial liver damage, there is inflammation, there are changes in flow. And what these factors promote? Well, inflammation and endothelial damage, which is not represented here, activate factor 10, and factor 10 promotes thrombin formation. But also thrombin formation, there will be microthrombosis, clot formation, areas of parenchymal extinction and collapse that they promote fibrosis. But also in the cirrhotic liver, there is inflammation, and there is an increased expression of protease-activated receptors, which are present in leukocytes, platelets, and stellate cells. And these are activated by thrombin itself and by the products of inflammation. They promote hepatic stellate activation, and they promote fibrogenesis in the cirrhotic liver. Also, you shouldn't forget that beside factor 10 activation, there is an increased thrombin generation as the chronic liver disease progresses. Therefore, the theoretical conditions for having microthrombosis in the cirrhotic liver, and this has been suggested that can contribute to the progression of liver disease. What can we do? Well, if there is inflammation, if there is microthrombosis, we can use, for instance, heparin. And we can treat cirrhotic rats with tetrachloride cirrhotic rats, and also thiacetamide cirrhotic rats with enoxaparin for 2 weeks. Well, we can take advantage of the antithrombotic and anti-inflammatory efficacy power of heparin. This treatment that was done by the Barcelona group, Juan Carlos and Jordi Gracia, they showed a reduction in portal pressure, an increase in portal blood flow, and a decrease in hepatic vascular resistance. Why? Because there was a significant reduction in the amount of collagen of fibrous tissue in rats treated with enoxaparin. Also, there was the activation of hepatic stellate cells with a reduction in those factors indicating activation of the cells, and a reduction in the expression of procollagen. And also there was a significant reduction in enoxaparin-treated rats in the amount of fibrin in the liver, indicating a reduction in thrombosis. Well, is this specific of enoxaparin? No. Because with rivaroxaban, they got similar findings. Reduction in portal pressure, reduction in hepatic vascular resistance. They didn't get such a sharp decrease in the amount of fibrosis in the cirrhotic liver, but they show it maybe a better marker as is a reduction in hydroxyproline content. The activation of hepatic stellate cells, a reduction in fibrin deposit. What this means that it is not a specific effect of enoxaparin, but probably of any other anticoagulant. Any other anticoagulant, as this one that is shown here in this very nice study, it's a model, an experimental model of Fontan. And this was a study done by Vijay Shah in the Mayo Clinic by Douglas Simonetto some years ago that, from my point of view, makes a very good relationship. Well, this is a model of partial inferior vena cava ligation. So there is an increase in systemic venous pressure. This leads to an increased pressure in the hepatic sinusoids that leads to thrombosis and passive congestion of the liver, of course. This leads to an increase in serous red stain, indicating an increased amount of fibrous tissue, activation of hepatic stellate cells, and increase in portal pressure. If we give warfarin, and if we use treatment of these animals with warfarin, therefore we block the coagulation route. So there is a reduction in the amount of fibrous tissue, the activation of hepatic stellate cells, and also there is a reduction in portal pressure. We get similar findings if we make partial inferior vena cava ligation in rats, in mutant rats with a mutation of the extrinsic pathway of the coagulation cascade, indicating that hypercoagulation leads or contributes to fibrogenesis in the liver. These are preclinical studies or studies in experimental models. What do we have regarding the use and our experience with the use of anticoagulations? In what setting? In the setting of portal vein thrombosis. And I have highlighted two of the questions that I want to address during the Consensus Spanish meeting. And these are the slides that I have taken advantage of the weekend lecture that I have. And the question is, should all patients with cirrhosis, recent, complete, or greater than 50% receive anticoagulation? Is anticoagulation a life commitment once we indicated it in a patient with cirrhosis? Well, probably you will say why this guy is giving us this information, because I think this is the main information we have, the main clinical experience we have in the use of anticoagulants in patients with cirrhosis. Those with portal vein thrombosis, we can get some information that will be useful for the combat trial. Using anticoagulants in patients with cirrhosis, although the evidence is very weak. But why we use them? Because we came, and Pierre Manuel knows it very well, this evidence comes mainly for the use of anticoagulants in patients with splanchnic thrombosis, in which they observe the efficacy of anticoagulants to recanalizate the hepatic vein or the portal vein and avoid the development of portal hypertension. So the pros for the use of anticoagulation would be a potential benefit in recanalization, as it has been demonstrated, a benefit in outcomes and survival. This has not been so well demonstrated, and if we use anticoagulants that we were very fear of their use at the beginning, now we are very confident because under certain circumstances they are very safe agents. And the cons would be that if most episodes of portal vein thrombosis are transient, why to use anticoagulants? Second, if portal vein thrombosis is a consequence of the increased severity of cirrhosis, and does not contribute to worsening of the natural history of the disease, why to anticoagulate patients? And also anticoagulants have some risk. And what is the cutoff of 50%? Very low evidence. About 40% of episodes of portal vein thrombosis are transient. And if 40% are transient, most of the transient episodes or most of transient portal vein thrombosis are non-occlusive with an occlusion of the portal vein lower than 50% and mainly in patients with child cirrhosis. Second, the evidence indicating an impact of portal vein thrombosis in cirrhosis progression and survival is not consistent with a negative impact of portal vein thrombosis on cirrhosis progression. In several studies, including this first one by Felipe Neria, multicenter French trial that you know very well, hepatic decompensation and death as independent of portal vein thrombosis in prospective observational studies. There are 3 studies that cannot link portal vein thrombosis with hepatic decompensation and death. And this retrospective study made, as far as I remember, in Japan, in patients with different severity of cirrhosis, follow-up 11 years, 100 patients with viral cirrhosis, retrospective study, US-based study in which they didn't observe any difference in survival in patients that develop and that didn't develop portal vein thrombosis. You see, these are the main studies, the main series of patients where we have to extrapolate evidence for the use of anticoagulation in cirrhosis. You see that the heterogeneity of the studies is very high. Also, the number of patients included in this series, none of them are randomized controlled trials. At most, they compare another cohort in parallel that they do not receive anticoagulants. As you see, all of the studies use low molecular weight heparin, low molecular weight heparin followed by vitamin K antagonist or only by VKA antagonist. Only the more recent series use DOACs. Another interesting thing is that the duration of anticoagulation, once has become more confident with the use of anticoagulants, they are extended the use of anticoagulation probably or sure beyond recanalization. And what are the findings? Well, all these people is treating portal vein thrombosis, although they are not very sure that it has an impact on the natural history of cirrhosis. But the results were quite good since the beginning. You see one of the many meta-analyses of most of these studies, recanalization with anticoagulation increases by 3-fold the rate of recanalization compared to the untreated group or the untreated cohort. Second, it reduced by 3-fold the rate of progression of portal vein thrombosis, again compared with the untreated group. Important to say that these are aggregated data meta-analysis, and the most recent, there is another one of 2020 that involves and analyzes the same studies. The most recent aggregated data meta-analysis suggests there is an improvement in overall mortality in patients with cirrhosis and portal vein thrombosis receiving these anticoagulants. And this is related to recanalization. We don't know. Only the study, the series of Vincenzo Lamura, showed that demonstrated an improvement, a reduction in portal hypertension-related complications in death and in a composite endpoint in those patients treated with anticoagulation that achieve a complete recanalization of the portal vein. Another advantage of anticoagulation is, well, I think I have been able to show you some of the risk factors that develop in the cirrhotic liver and that favor portal microthrombosis and also thrombosis of the portal vein. Once we stop anticoagulants, those risk factors remain there. And most of our researchers, there have been many disagreement in that question for the Spanish consensus, is that if you stop anticoagulation, the risk factors remain there. So the risk of recurrence is very high. In meta-analysis, almost 50%. From my point of view, and the main series addressing this issue is around 30%, sometimes very close to the point of stopping anticoagulation. And in the Spanish series was as close as between 1 and 2 months. So there could be an improvement in survival. It can prevent or recurrence is frequent after stopping anticoagulation. An individual patient data meta-analysis, well, those are aggregated data meta-analysis. But we performed an individual patient data meta-analysis in 5 studies that were those that answer our request for having individual data, 100 patients, and we were able to observe and to demonstrate that an overall improvement in survival in a competitive risk model using or with liver transplantation as the competing event, an improvement in survival, a reduction in mortality in patients receiving anticoagulation. Once we adjusted that, we were able to do that because they were individual patient data, but age, etiology, and mainly by the severity of liver disease, thrombosis station, and localization of the portal vein thrombosis. And what is important is that the improvement in survival survival was independent of the severity of the occlusion of the portal vein and independent of achieving portal vein recanalization. There have been another aggregate data meta-analysis after we close the individual patient data, and both of them are in the same direction. One from the United States, an improvement, it is not significant, but an improvement in overall survival in patients treated with portal vein thrombosis, treated with anticoagulants, and another one from Romania, which shows a significant and statistical significant difference. It is enough to show the study by Lofredo and Bioli that show that once patients are protected and receiving variceal bleeding prophylaxis, anticoagulation either with a low molecular weight heparin or with warfarin following low molecular weight heparin does not increase the rate of any bleeding or portal hypertension related bleeding, showing that this is safe once we take care of giving our patient adequate variceal bleeding prophylaxis. And we have been talking about warfarin, we have been talking about heparin. What about the direct anticoagulants? There is a meta-analysis of almost everything. This is a network meta-analysis that show that compared with low molecular weight heparin, warfarin, and sequential treatment, there is direct anticoagulants have a high efficacy than heparin and warfarin to achieve complete recanalization, partial recanalization, and without changes of differences in mortality. Also, there are no differences in bleeding using those different types of anticoagulants. Just another study, another meta-analysis from Francesco Bioli to show that the high safety of direct anticoagulants, they call advanced liver disease, that were patients with significant fibrosis and cirrhosis that were receiving direct anticoagulants because in the prophylaxis of a stroke, patients with atrial fibrillation. These agents were safer than, in this case, vitamin K antagonists. Lower rate of major bleeding, intracranial hemorrhage, all bleeding, and GI bleeding. But in our case, those agents cannot be used because they have advanced cirrhosis. My recommendations, which are the same that we discussed that early morning before Baveno with Jean-Pierre, Jonel, and Dominique, is that in non-liver transplantation candidates, which is a quite wide, broad concept, liver transplantation setting is another setting, we have to individualize extending the use of anticoagulation beyond recanalization because it can have an impact on survival and it prevents recurrence of portal vein thrombosis. What data suggests that anticoagulation improves survival in cirrhosis? And the first study was this one by Erika Villak, that for sure you all know very well, which used a rather low dose, a prophylactic dose of enoxaparin, that it was given to patients with child B, C10 cirrhosis, in which 48 weeks of this treatment prevented portal vein thrombosis and reduced hepatic decompensation and improved survival. It was interesting to observe that, of course, the reduction in portal vein thrombosis, enoxaparin treatment was an independent risk factor of avoiding portal vein thrombosis. But also it's important to say the compensation and survival were depending. The independent risk factor was enoxaparin treatment, but not appearance or prophylaxis of portal vein thrombosis. And also it's important to highlight that treatment was given for 48 weeks, but the opening of the curves and the decrease in hepatic decompensation and improvement in survival extend far beyond the point of stopping anticoagulation. The second study that, from my point of view, indicates a beneficial effect of anticoagulation in patients with portal vein thrombosis is our individual patient data meta-analysis that is under review right now. And the third study is this study evaluating the safety and efficacy of direct oral anticoagulants compared with warfarin in a similar population as the meta-analysis that I previously showed you of Francesco Bioli. You see that compared to patients that did not receive treatment, warfarin reduced all-cause mortality significantly and also direct oral anticoagulants. The same benefit was observed when addressing hepatic decompensation, although the difference may be because the different population severity of the disease in the populations did not achieve significant differences in patients treated with DOAC. Lastly, just to say that the cumulative risk of bleeding was even lower in patients receiving direct oral anticoagulants compared with warfarin. So my conclusions are quite simple. There is microthrombosis in the cirrhotic liver that might contribute to cirrhosis progression, and there is a potential benefit of long-term anticoagulation on hepatic decompensation and survival in cirrhosis that I think set the stage for the use of anticoagulation in the trial you are proposing. And what drug we can use? Well, we cannot use direct oral anticoagulants, which would be the best drug for long-term treatment in this case, but we have problems. They are contraindicated in patients with advanced cirrhosis. Vitamin K antagonists, they have been quite safe in those studies in portal vein thrombosis, although there is an unreliability of INR in cirrhosis, and all know that we are more confident with the use of heparin. So short half-life, renal excretion, we have to use subcutaneous injection, but we have 90% biodisponibility after the subcutaneous injection. So maybe, and I would say that this drug is probably the winner for the combat trial. And thanks for your attention, and we can discuss whatever you wish. Thank you.